Good evening, ladies and gentlemen. Welcome to Politics in the Pub. My name is Joe Nagy, and I will be chairing this meeting, Medicare, Key Plank for Social Justice, now under threat by the Abbott government. We are privileged tonight to have two expert speakers on the subject. Professor John Dwyer, Emeritus Professor of Medicine, University of New South Wales, and Dr. Con Costa, National President of the Doctors Reform Society. Now on to Dr. Con Costa. He completed his medical studies at the University of New South Wales. He then worked as volunteer doctor in Bangladesh and Thai refugee camps before completing a postgraduate degree in public health at Sydney University. Con has worked as a GP in Sydney's Inner West for more than 30 years. He's a Foundation Fellow of the College of Public Health Physicians. Con has been involved in public health policy and health politics for longer than most of us care to remember. His commitment goes back as far as the successful grassroots campaign to save Canterbury Hospital in the 1980s, opposition to the dismantling of Medicare by the Fraser government, and a campaign against the Hawke government's co-payment. Interesting, isn't it? Hawke government's co-payment. This was successfully overturned when Paul Keating took over as leader of the Labour Party. Con is a passionate supporter of the people's right to health care and reducing power and influence of vested interests, including big pharma, through public advocacy and grassroots campaigning. He has been on the national executive of the Doctors Reform Society and the national president of that organization during the 1990s. Last year he was again re-elected as national president after a long stint as senior vice president. Dr. Con Costa.
Thanks, John. That was really good. Spending $5 billion would save $30 billion in hospitals. Really important to get that message out. And the fact that the government, our politicians aren't tackling the waste, and health has become a policy-free zone. Policy-free zone for our politicians, who all seem to have become, all the ministers seem to become ministers of private health insurance rather than ministers of health. So, look, I'll cut to the chase, because you probably don't want a long-winded talk. I think what we need is more than just ICAC to move to the federal level. We've seen what ICAC's found at the state level, and it would be definitely a good idea to take it to the federal level. I say that not because I've got any evidence, but it just seems perverse the way the system seems to be working. And I would have thought ICAC would bring a lot more transparency to the table. But more than that, that we need a royal commission into the health system. A royal commission into the health system. And I don't say that lightly. We can see that there's massive changes occurring in health. Companies like BUPA, B-U-P-A, British United Provident Association, multinational health insurance, is now, along with Medibank Private, a virtual duopoly of private health insurance in this country. The first we heard about it was when Christine Bennett, whose only claim to fame that I knew of was that she was an ex-BUPA person, was put in charge of Kevin Rudd's National Health and Hospital Reform Commission. So I think it's been 5 years, it might have been more, I don't know, the years seem to go by a lot quicker. Now suddenly BUPA with Medibank Private is a virtual duopoly. I know that Mr. Cormann says we have a very healthy, competitive private health insurance and 32 providers, but effectively it's run by 2, and one of those is about to be sold. So it raises questions, doesn't it? It raises questions. I'm not going to say anything, but it raises questions. So a royal commission would be good into the connections that private health insurance funds and big pharma have with our politicians. And whether those politicians, how come those politicians can so easily retire from politics and slide into well-paid jobs with those vested interests? But even more importantly, a Royal Commission could look into the neglect of the elderly and the infirm in the health system. The absolute neglect. of old, sick people, people in nursing homes by the system at the moment. A Royal Commission could look into the perverse incentives in primary health care, which John Dwyer touched on. And I guess the best way to explain this is our public hospitals is where you want to be if you're sick, and we all know that. And that's because the public hospitals are team-based. There's the nurses, there's the doctors, there's the social workers, there's the physios. The team works together, and they work together on the most serious cases, and they prioritise according to need. But the interns, although the ambulances bring in the serious cases and they focus on those, they still take care of the cubicles, which is where the GP-type patients come in as well, and that's a minor part of the hospital, yeah? So everyone's taken care of. But the emphasis is on where the need is. Whereas you look at general practice, and it's the reverse. All the doctors are in cubicles, taking care of the mobile patients, and all that vast amount of palliative care, mental illness, elderly, people in nursing homes with bed sores who can't move, who can't afford a specialist, who are being taken care of by, as it becomes more and more privatised, more and more de-skilled, cheaper labour, right? And where GPs no longer want to go. So it's become a doctor-free zone. It's become a registered nurse-free zone, if you like. So I think a Royal Commission could well look into this, why this abnormal focus, why Medicare and primary health care has become a policy-free zone by government. Why is Medicare being run into the ground? We could look at the waste in the health system, which John also alluded to. Why is it that an ophthalmologist can make $40,000 in a morning? Why are we paying $40 for a cholesterol tablet that's only off patent and only $2 in Great Britain or $3 in New Zealand? Why is there a policy vacuum when it comes to Medicare? Why is Medicare being run down? Why are the private health insurance funds now allowed to provide instant or better access for the private health insurance patients to the GP? And after-hours calls when a lot of uninsured patients don't get that, and when it's illegal to do it anyway. And why is that okay with our current health minister? A Royal Commission could look at the power imbalance between the vested interests and the patients, because it's a question of power now in the health system. You've either got it or you haven't. Why dental health is so abysmal, it's such out of the reach of so many Australians. Why Indigenous health continues to suffer so badly. And recently we've had the Prime Minister taking the photo opportunities. I think you've seen all the photos, and poverty is very picturesque. I don't know, maybe I missed it. I didn't hear about the initiatives on Aboriginal health and the fact that a co-payment would virtually knock out all the Aboriginal medical centres, because no one's going to pay the co-payment, and if you don't pay the co-payment, the doctor's income is halved because there's penalties involved. All we heard about was talks about spending more money on a war that our Parliament has not approved of. And interestingly, I didn't see Mr Hockey or Mr Cormann budgeting it and telling us how much it was going to cost and how we're going to pay for it. Because that's important, how we're going to pay for this war. The aircraft, as I understand, cost $20 billion. I digress here. $10 billion to maintain them per year, I think. And $500 million to go on this bombing mission for our American friends, which is sort of ironic, given now it's the 100th anniversary of Gallipoli, and only 100 years ago we went on a war mission for our English friends, but we don't seem to learn those lessons. But back to what I was saying is, well, where's this money coming from? We've got a supposed revenue problem, can't afford Medicare, can't afford healthcare, can't afford education, can't afford higher education, can't afford unemployment benefits for people where there's no jobs for them. So if we're going to sell Medibank Private, Medibank Private's one of the highest revenue makers of all the government assets, $500 million a year. That will be a permanent $500 million a year black hole, if there is a budget crisis, if you ascribe to that. There's $500 million a year now to go and bomb the Middle East. And our government hasn't even costed that. So obviously that means there's going to be less money for these people I was talking about, which are the elderly in the nursing homes, Aboriginal health, dental care, whatever. But it's just interesting that when we talk about healthcare, it has to be budgeted, but when it comes to a war, the money's just going to appear from thin air. When I say a policy vacuum, there is policy going on in primary healthcare, but it's by the private health insurance funds. They want to put doctors, salaried doctors, into the nursing homes because they've realised it's much better to treat people in primary care much cheaper, and then they don't end up in hospital costing the private funds a lot of money. Well, why aren't we doing that with Medicare? Why aren't we giving better access through Medicare? Why aren't we providing after hours through Medicare? So I think a Royal Commission would be a really good thing, and I think that's what we should be calling for. We should be calling for it not just for all those elderly, infirm, sick people that are being neglected and getting second-class health care, but because one day we're all going to be patients. So there's self-interest there as well. On top of that, we should call for the Productivity Commission, I don't know if people know about that, to look at the way we're spending money in the health system, including the private health insurance rebate. The Productivity Commission is there when the government wants something analysed, but they never ask these questions. Because if they did, the Productivity Commission would say the private health insurance rebate's a colossal waste of money. And that would go against what the Minister of Private Health Insurance wants, which is to keep giving them private health insurance. So we pay 30% of that through our taxes. So let's call on the Productivity Commission, let's call on the government to get the Productivity Commission to look at what John was talking about, this enormous waste in the health, including the private health insurance rebate, but also why are we paying $40 for a generic cholesterol tablet when it's only $2 everywhere else in the world, and why ophthalmologists can still make $40,000 in a morning, but we can't afford to pay our GPs who are doing the really cost-effective work. Well, there, I've said it. That was going to be the main thing I wanted to say. On the co-payment, it's still on the agenda, and you wonder why. You wonder why I mean, Mr. Dutton said he wanted a dialogue. He brought in the National Commission of Audit, headed by the Business Council of Australia ex-head, and Business Council of Australia members, top 100 rich list includes Bupa, there's that name again, Bupa, and Medibank Private. And he said, over-servicing, seeing the GP too much, 11 visits per year, turns out it's only 5 and he double counted. We had the discussion, and huge amount, and I think we don't want to bore you with it again, but enormous weight of evidence that this is a crazy thing to do. Stop people from seeing the GP, they're all going to rush to the hospital, you're going to lose the doctors in the country areas, Indigenous areas, out west, working women would no longer have a GP to do their preventive checks, a million reasons. And what happened after all that? Mr. Dutton said we're going to press on with a co-payment. So I don't get it. I don't get it. So we have a dialogue, we provide the evidence, but we pursue policy which even their side of politics has said they should abandon. So we're still stuck here discussing a co-payment. Do you all know how the co-payment works? The idea is they will cut the GP's rebate by $5. You will pay $7 initially. If you don't pay the $7, they'll cut the GP's Medicare incentive payment, which is another $6, and in the country the $4 rural loading. In other words, the GP, if he doesn't get any money out of you, is going to lose $15 out of $37. If his income is only 20, 21 or 22 after costs, he's effectively losing 60%, he or she are losing 60% of their income. So clearly in areas where people can't pay or the doctor can't charge, the doctors aren't going to stick around. They're not going to stick around. And Mr. Abbott would know the significance of that, because it was Mr. Abbott who introduced the Medicare Plus item of $6, $5 back then, increased to $6 now, when he was Health Minister under Howard, to stop the collapse of bulk billing, because the Medicare rebate was just going so bad. All the doctors were stopping bulk billing. So he introduced $5 to keep bulk billing going, and now they're talking about reducing by $5 initially, but as we said, up to $15. So what's going on? What's going on? They keep saying that Medicare's out of control. It's not primary healthcare spending that's out. Let's get this very clear. Primary healthcare spending is not out of control. I think it's been static for the last 10 years. What's out of control is the hospital costs, which Professor Dwyer alluded to. And the only way to get a control of those hospital costs is by getting the GPs to work more effectively and see more people, for people to go more often. Yeah? So the problem we've got is how to get better value out of Medicare, and I think I've already alluded to that. The doctors should be based in nursing homes, the doctors should treat dying patients at home, they should provide house calls, and should underemphasise sitting in their offices checking blood pressures and blood sugars, because if they were in a team, the nurse practitioner could more than take care of all that. The doctor's there for the diagnostic stuff, the heavy stuff. We've de-skilled our doctors, we've reduced their professionalism, we've got them all sitting in the cubicles. Remember what we said about the cubicles? We've got them all sitting there doing the minor stuff. And we could get a lot better value. We don't need to increase the spend on Medicare. But where's the policy? Where's the policy coming? There's no policy on public health or Medicare. It's all about boosting the private sector. I talked about the sell-off of Medibank Private, because that is coming up as an issue. They're going to go ahead with that. It's not just that it's a 500 million black hole in a budget that apparently needs every cent it can get. Yeah? If we haven't got revenue, why are we selling off a really good revenue maker? Yeah? But it's more than that. It's the privatisation of the health system. The sell-off of Medibank Private in the end is about the privatisation of the health system. And they couldn't argue about, they sell everything else off because they say they need the money, but with Medibank Private, they turned around and said, oh, it's because government shouldn't be involved in private health insurance. Or the thing is, we're paying taxes, and they're using our taxes now to pay for 300, I think it's, I've heard, I could be wrong, I stand to be corrected, 300 PR, public relations people. Is that, anyone else heard that figure? 300 public relations people to sell the government message, which is that we should spend 30 billion on warplanes and we can't take care of our elderly in the nursing homes. So that's pretty poor, and I guess I just wonder whether that is why the photo opportunities this week in the Northern Territory, but maybe I'm being a bit unfair there and a bit cynical. I think one thing we can be the one thing good that's come out of all this is that the roadmap, which hasn't really been revealed to us, they always slice the salami, and we're getting bits of slices all the time. But with this government, they seem to be a bit sloppy in that they've shown us the roadmap. And as John said, they're not just going to, they're still pushing for this crazy co-payment. They're still pushing for it, but also massive reduction in the federal share of public hospital funding, which means the only alternative for the states is going to be a GST of 15%, which is again a direct tax, which means paid more by the poor, increased burden on low income, and probably push the states into charging for emergency department visits, which currently cost the state government $290 on average if you go to the emergency rather than to your GP for $36. $290 instead of $36. And it seems that what the government wants to do in the end is fund the war machine and the police, and the rest is user pays. That just seems to me the crazy way we're going. Which is crazy, because even the Americans recognise that their private health system, I think it was Warren Buffett said, is the tapeworm of the American economy. He said that, yeah. But can I just please put a plea in for the elderly, because we're all going to be elderly and frail pretty soon. Residential aged care in Australia are mostly women. The majority are over 80, many are widowed. There's 170,000 as of 30th of June 2011, it might be 200,000 now, almost on a permanent basis. There's 2,760 facilities, I think half are not-for-profit, the rest are for-profit. And they're becoming bigger. 50% now have 60 places. Many of those people in there are high care, high dependency people. Not only have they lost their vision, their hearing, arthritis, diabetes, dementia, blah, blah, blah. They're not getting health care, or they're getting neglected health care. And I say that because at the moment, all the GP really needs to do, or all the facility usually wants, is for the GP to come once a month to write up the medication charts. And the patients are on 10, 12, 20 tablets, just got to write them all up. Many of these people, their health changes from day to day. And what happens is the staff is untrained, they don't want to disturb the doctor, certainly if it's after hours, they ring the ambulance, the patient goes to hospital, huge cost, ambulance, emergency, some of them are admitted, the young doctors there don't know them, so they admit them to be careful, thousands of dollars a day in costs, huge inconvenience to the patient, and it's hard to get a GP to visit a nursing home because they're too busy, as we said, in their cubicles, in the cubicles taking care of the mobile people. It's like taxis, you know, with doing taxis, much more profitable to do lots of short trips. No one wants to take you out to Penrith or the Blue Mountains. And that's the problem. The people we need to be taking care of, really, are the ones that are really sick and complicated and need a lot of time. At the moment, very few GPs do house calls. There's locum services available for if you call someone after hours, they're usually, even the locum service will tell you, they're very untrained, very inexperienced. So there's a disconnect between the GP and the after hours call. And people dying, I think the figure in Sydney is maybe 40 or 50% of people having palliative care for cancer in Sydney don't have a GP. Wow. Much less, and even those who do have a GP, don't have a GP who's going to go and take care of them at home. So where do they die? Where do they go for their care? The hospital. Where do they die? Intensive care unit. That's very expensive, and it's very unhappy for the patient. That's why I say, I'm not being silly when I say we need a Royal Commission. We should not be treated like this. So Medicare has become an information and policy-free zone. Everything they're saying about Medicare, to argue for a co-payment, is either wrong, false, or non-corroborated. They don't have the figures, they make up the figures. Many people now actually, many of the elderly, many of the sick, they don't call a GP, they call an ambulance and they go to hospital. It's a crazy way to run a health system, crazy. A Royal Commission into this, and a Productivity Commission looking into the way we're spending the money, would certainly be a good way to go. So finally, to sum up, we must oppose the co-payment at all costs. It's not about an attack on Medicare, just that it is, but it's more an attack on primary health care. If we lose primary health care access and we go over to private insurance and hospitals, the health system costs they'll go through the roof. So it's a crazy thing to do. We must stop this push of private health insurance into general practice. I haven't got time to go into all that. At the moment, they're paying GPs under the table to see privately insured patients quicker and to do house calls on them. Which means, if you haven't got private insurance, your wait becomes longer. It's a two-tier system. We need to bring back pro-Medicare policies such as salary GPs, team-based care, which is being proposed by the private health funds at the moment, but our government stays silent on Medicare. No sale of Medibank Private, and let's look at the connections between Bupa and the private health insurance industry with the Minister, with government. Let's move ICAC to Canberra. If we're going to lose our health system, we should go down screaming and fighting, I'd say. And of course we need to change the power structure in the end. The vested interests, the AMA has their offices in Canberra, I'm sure the private health insurance funds, Big Pharma. The dialogue needs to be between the people and the government, not the vested interest and the government. Lastly, if you are a bit upset, there is a rally on Saturday that I was invited to. Yeah. And what I like about it is that it's actually something you can do rather than sit and get depressed. And that's marching on Mr. Abbott's office, because I think he will be influenced. And it's 1 p.m. Saturday, that's this Saturday, Manly Park, then march on to Tony Abbott's Manly office. Yeah, so I think that's
no position description, that's good.
Okay, right.
That's okay.
Well, it's always good to leave it with something to do rather than just get depressed about the situation.
Thank you.